Today is July 5th. It's the day after the U.S. Independence Day here, and we all survived another day with firecrackers and all sorts of things. So I'm always grateful that none of my family or friends have been injured. It's an incredible experience always to be amongst that. And it's so nice to be without masks. Our hospital has finally released us from the mask obligation, so we're free of that. Today's a very special day for myself personally, and that is again, Dr. Tarush Rustagi from Delhi is going to speak today about C-spine fixation and posterior C-spine fixation. Tarush, are you live?
Yeah, I'm here, Dr. Chapman. Thank you.
Good morning. We'll introduce you formally later, but as always, we'll start with some cases, and we have 4 or 5 cases. I'm seeing you, and you look great. You look even better than your picture. I'm very curious about your title today. I didn't quite know what to think of it in terms of posterior C-spine fixation, so we thought we'd show you some C-spine cases from our recent practice and ask for your opinions, okay? So Dr. Jared Cook, who's one of our outgoing fellows, is going to talk about 2 cases that he recently discovered and saw and was involved with. So go for it, Jared.
All right, thanks for the intro.
And Dr. Cook has spent the last 2 years with us, and he's going to go to Virginia. And he came from New Mexico, so.
Yep, going to Virginia Beach. All right, so our first case is a 63-year-old female with neck pain radiating to the posterior head, worse on the left side than the right, symptoms for 10 years, worse with rotation, improved with traction. Injections have not been helpful. And past medical history, multiple sclerosis, anxiety, depression, normal neurologic exam for the most part. And here's what we see on X-ray. You just see, mostly degenerative changes. You have that 4-5, but not correlating with her symptoms. So then here's what we see on the CT exam. So really what we want to call attention to is the, can we see the cursor? So you have the left-sided like severe arthrosis of the C1-2 joint, and then also the cyst formation in the odontoid. And then what we can see also on that leftmost image is we have the vertebral foramen essentially just right next to each other in C1 and 2 stacked on top of each other. Here's what we see on MRI. So mostly open in the central canal, no impingement on the spinal cord itself. So what we have at this point is a C1-2 destructive facet arthropathy and some radiculopathy.
So Jared, does this lady have inflammatory arthropathy signs? Does she have crippled fingers, hands, wrists, shoulders, hips, knees, etc.?
No, she doesn't. I mean, the only thing that would suggest something like that is the that cyst formation in the odontoid. But otherwise, no, I don't recall her having any of those signs.
Okay. And go back again to that CT. I think that was the most evocative. So no myelopathy, no major typical radiculopathy, headaches. Tarush, what do you think about this kind of a destructive arthropathy? What are you thinking of? Is this a genuine cause for neck pain? Is this something you've seen, these kind of unilateral atlantoaxial arthropathies?
Yeah, I mean, as you said, they aren't really common, but yes, we do see them once in a while. They can be causing a lot of, especially posterior occipital headache with no major radiculopathy or in the arms or any myelopathy. So they are really tricky to treat. Sometimes they do respond well to occipital blocks and greater occipital nerve blocks. And the other thing that, as you already mentioned, it could be associated with some inflammatory disorders, especially some crystal deposition diseases as well. But in the absence of those, I think it's just a typical advanced degenerative changes involving the C1, C2 more on one side.
So those are some excellent points. So inflammatory arthropathies, autoimmune diseases, and crystal deposit diseases are things that we want to look for. And I think Reiter's is one of the things that I forgot to mention before, psoriatic arthropathies. And again, she did not have any renal disease. She did not have any gout or deposit diseases. This is just a pretty nasty, destructive disease. I think she had 1 or 2 injections. I'm not sure what they inject there, actually. Do they just, would you in your center have the interventionalists target the C2 route, or would they try to inject the joint itself?
No, I think they would, we will definitely send them to the pain center and they would try to inject the C2 route there. That's the area of target.
To give these patients a neck immobilization in hopes that this can kind of just heal itself, or what are your thoughts on this?
Well, I mean, truly depends on the patient. If the symptoms aren't very significant, then they can be observed for, for a few months and see if things are settling down. But again, depends totally on the symptoms.
Great. So she's gone on for a while with this now. She's pretty crippled from this, right? And the only medical comorbidity that I remember was she had MS, right?
Yeah.
Did she have a fine tremor also, or?
No, she didn't.
Yeah. So she went on for quite a while with this. So what would you do with this then if she truly failed? She was very compliant, is a nice lady. She has reasonably well-maintained MS without exacerbations. What would you do with her, Tarush? And she has this weird C2 anomaly with these bad vertebral artery excavations.
I think understanding the course of vertebral artery is critical in planning these surgeries, especially looking at the anatomy of the C2 pedicle screws, making sure there's no high riding vertebral artery or any excessive medial course of the vertebral artery. If that's the case, I think it's fair to do, considering doing a C1, C2 fixation. So that would be sort of my first thing in my mind to go ahead with.
Good. And what would you do for C2 fixation? I mean, she has, again, these medialized high riding arteries. She does not have a big C2 column. What kind of C2 fixation would you give her?
The options would be either to try and put in laminar screws as well, depending on how big the laminars are, or one can also consider going down to C3 as well, because there aren't much motion between C2 and C3 in the worst case scenario. I think I would be pretty okay going down to C3 as well in this case, or even C4 for that matter.
And then the age-old question, what do you do as fusion material? Do you fuse the actual joints? Do you do an onlay fusion like a Zontag fusion, or one of the good old Galley or Brooks fusions, or what do you do there?
Yeah, actually, for all practical purposes, I think what I personally would have done is just, follow the C2 and open up the C1, C2 joint, use the curette just to curette it out and added some bone graft in between, and they typically heal pretty okay.
Well, this is going to be a boring day because we concur. So let's take a look at Jared. Maybe you can criticize what we did.
All right, so I went for a C1 to C3 posterior fusion, left C2 nerve root ligation. We did the C2 laminar screws. That went just fine. As far as that left C1-2 joint, it was very collapsed. Did the nerve root ligation and then opened up the joint with a structural graft, and you can actually you can see the right-sided graft in actually a little bit over here on the bottom of C1 on that image. You can't see the left side. There is a little bit of tilt, but it's largely corrected. Here's final results. So then after surgery, she has that predictable numb patch on the back side of the head that she was told about beforehand. The pain that she was experiencing prior to surgery is largely gone. At this point, it's just surgery pain left over. I'd say that we went after the right target there.
So in terms of laminar screws, there's some surgeons here in the US that for C2 fixation mainly do translaminar screws. Pars and pedicle screws are almost unheard of. Is that similar to your practice? They claim it's easier to do and safer. What are your thoughts in terms of safety, and what's the preponderant posterior C2 fixation for you, Tarush?
For me, I think it's much more difficult to put the laminar screw, to be honest. It always breaches the lamina. I think in our practice, in general, we definitely C2 pedicle screw is the first option, and laminar screw is kind of a salvage or extra fixation point situation.
I think that's very interesting because we had a similar conversation. Can you elaborate a little bit? What is harder for you to do in terms of C2 laminar screws? Why do you not like it as much?
Yeah, it's pretty complicated, I think. Putting two laminar screws, there's always a chance that they're going to cross each other, although they have been very well described how to put them, but there's always a chance that they're going to breach the dorsal lamina or the ventral lamina. So I always find them a little tricky and always find it easier to put in one laminar screw instead of two laminar screws.
So one very good question by Dr. Farzin Farabaksh. I appreciate your question, Dr. Farabaksh, a lot. Do you always get a CT scan prior to such surgery, or is an MRI and plain X-rays enough? I'll go for your opinion first, Tarush. I mean, we like to get CTs. Obviously, we like to see the bone anatomy in great detail, but is that necessary?
Yeah, I mean, a CT scan is definitely useful just to critically, look at the anatomy and understand the problem. X-rays can be really, not very clear, especially in the upper cervical spine and cervicothoracic junction also. They don't give a clear picture exactly what is happening. So yeah, I think CT is something that is extremely useful, even more than the MRI in most cases.
My add-on to that is it helps me understand the type of arthropathy. If you don't mind going back, Jared, if you look at that arthropathy pattern, this is again a hyperplastic sclerotic bone. There's bony erosion in there. The erosion goes into the C2 segment and into the odontoid base. Then no calcium deposits in there. This is obviously an erosive and a progressive disease process. To me, the leading diagnosis would be psoriatic arthropathy, followed by some urate or other deposit disease that we just can't specify. We found glassy tissues in it, but it's not anything special. But did you get the coronal CT, by the way? The particular concern that we had, you don't have that CT, is the vertebral artery on the left side actually literally sat on the joint or was communicating with the joint, and we were very careful with how we scraped that, and we built that up with a structural allograft. You don't have a coronal CT of that, right?
Not the post-op one, no.
Yeah. So we built that up and we rebalanced her head. So she was actually quite pleased. She left after one day, and again, she has a numb patch now, but we told her about that. Any critique on what we did? Do you mind going forward again?
I think it's beautiful, as always.
So I concur with you that I don't like translaminar screws, and for me the big problem is always we have to dissect out way more lateral so we get this oblique angle. I don't like to do percutaneous poke holes in there. So for me it's actually not the default, but it's a secondary, almost a salvage option. And we had planned on translaminar screws, and I was not willing to just do short pars screws, and I was not comfortable doing pedicle screws. Tarush, do you use a navigation to put these upper C-spine screws in?
Not routinely, but sometimes if we have to put pedicle screws, we do use navigation, but not routinely.
And I want to just recognize the game-changing input that Dr. Goel had, not Dr. Harms, in terms of describing C1 lateral mass screws. Historically, we would have had to go most likely to the occiput. Trying to do trans-articular screws, and that would have been crazy, but I do want to recognize Dr. Goel. We just talked about him the other day and had his original article for review. I think that was done like a decade before Dr. Harms's C1 lateral mass screw. Was that right, Jared?
Yeah, sounds right.
Good. But yeah, so this was a game changer for us, and I think for patients, by preserving the craniocervical motion, that was a really big deal. So let's go for case 2 from your end.
So case 2 is a little bit less straightforward. Well, from our part straightforward. You'll see. So this is a 67-year-old male transferred from an assisted living facility with 4 days of right upper extremity pain that they were trying to treat with Tylenol that wasn't working. They described it as kind of a burning, neuropathic type sensation. This patient had gait dysfunction for about 4 years, maybe even a little bit more. Described it. When I talked to him as unsteadiness on his feet, he was having a bunch of falls at that point. So he's been in a wheelchair for 3 years, bilateral upper extremity dysfunction for 2 years, medical history, obesity, non-alcoholic steatohepatitis, and diabetes, chronic kidney disease, stage 3, no prior spine surgery. His exam is pretty limited, decently strong, but not, enough to hold himself up. His coordination was really the main issue that he was having. And then you just kind of see the pertinent lab values there. So here's the timeline that, that we got from on admission. So about 4 years ago, having gait dysfunction, low back pain, and taken to an outside spine surgeon, diagnosed with lumbar stenosis. The stenosis was treated non-operatively. It's unclear on whether the gait dysfunction was actually, discussed at that appointment or anything. There are no notes from that. Just an image showing the stenosis, which I'll show you in a minute. All of the dysfunction was, chalked up to this, lumbar stenosis, and his family placed him in a wheelchair because he kept falling. And then 2 years ago was having bilateral upper extremity dysfunction with numbness that was assumed to be diabetic neuropathy. And at this point is eating with, built up utensils. So essentially kind of Coban taped, so that, he can, be coordinated enough to, to eat. And, here's the stenosis that was, I guess, potentially blamed for, for the patient's gait dysfunction. Keep in mind the records from outside facilities are very limited, but cervical spine workup was never done. And so we immediately ordered cervical spine, MRI, and, this is what we see. So at C4-5, it's a, pretty stenotic C5-6. The spinal cord is severely impinged, cord signal change, and so the colors for the boxes correlate with the level here. So this is really kind of what we're looking at. I hope it's showing up well on the outside monitor. It's a little dark here. So the patient's MJOA score was 5, and it looks like, kind of straightforward, just untreated cervical myelopathy. So that central stenosis was, probably the culprit this entire time. And at this point, the patient is a NURIC 5. The NURIC rating scale is, here for you to see. So, at this point,
Do you mind going back to the C-spine MRI? So for me, this is, as you know, Tarush, we talked about this when you were here in Seattle, one of those ongoing frustrations. Here we have, quote, first world medicine. We have, I don't even know how many MRI scanners just in a 5-mile radius here downtown Seattle. And this patient had seen spine surgeons. He'd everybody concentrated on low back pain, yet the painless paralysis or quadriplegia emanating from his neck somehow did not strike anybody. And he had a much delayed recognition of cervical myelopathy. Is this something that you see? I mean, how do I begin to wrap my head around this kind of pretty substantial failure? Obviously, comorbidities like diabetes don't help, and the presumed diabetic neuropathies, which are a ubiquitously thrown around term. So help me understand how we can do a better job at population health management, as we have probably 30, 40 plus MRI scans just here in a stone's throw from our center.
Yeah, unfortunately, that's the reality all over. And we do see patients like this even here, where they're just completely missed as far as the cervical stenosis is concerned. Essentially, the problem lies in the, not the proper examination of the patient and, how they're treating the patient. That's very important. Some of the things that we have been advocating, and hopefully at least in cities is pretty common nowadays, is whenever we ask for an MRI of the lumbar spine, it's almost a norm here to screen the entire spine, irrespective whether we ask for it or no. I'm not very sure how easy or convenient it is over there. So we always screen the entire spine, whether they have a cervical problem or a lumbar problem. There's always one kind of at least 5 or 6 shots to screen the entire spine.
So is that a sagittal survey scan? Is that like a T2 sagittal screening MRI that you get, or what? Because this is fascinating for me, and this is actually a really, would be a very nice troubleshooting solution. How do you handle that socioeconomically?
Yeah, I mean, the MRI is very costly over here. So exactly as you said, it's a T2 SAG screening shots, at least 4 or 5 parasagittal, central, and right to left sided cuts. So it typically doesn't miss anything. Even if there is a slightest of suspicion of any compression going on anywhere, then a dedicated scan can be done later on.
Again, I want to recognize several contributions from our South Asian colleagues from India, specifically about tandem disease, together with some of our Korean and Japanese colleagues. The recognition of this tandem disease of cervical and lumbar disease has been published and brought to the attention of everybody. And I actually really like this idea of sagittal screens. We're starting to see that more for oncologic and infection indications. When you were with in Ohio with Hudi Mendel, was that what they did, or did they do proper full neural axis MRIs there?
No, in the tumor world, they would just do the MRI of the entire spine. Dedicated MRI of the tumor containing area, and then the screening MRI of the remaining spine. That's always kind of a norm that was there.
Yeah, so your conjecture that a screening sagittal MRI might be helpful was also reflected by Dr. Farag Bash, who basically identified 30% of patients who have bad lumbar stenosis probably have cervical disease also. And so revisiting the subject of doing a cervical screening sagittal pan scan might be very helpful in this regard. Well, we didn't do this, and this patient is now wheelchair bound and severely diminished. So he's a neuric 5, and his MJOA is single digits. If you go back again, so if you go back to the chart, yeah. So this is a pretty bad situation now. Do we still offer this patient surgery? We had the Ranawat criteria also, which was a functional scale, a very simple functional scale, more for atlantoaxial disease. But basically, back in the 70s and 80s, I was taught the Ranawat scale, and that was basically if a patient was a 2B, which was the worst wheelchair-bound situation, surgical care was not recommended. What is your thought? Should we give this gentleman a chance to recover? I mean, he's, again, wheelchair-bound. He's in full-time care and has been for years now, right?
3 years in a wheelchair.
3 years. 3 years in a wheelchair, no MRI.
Yeah, so that's a real problem. I mean, a lot of emphasis has to be given in counseling this patient about the outcome of surgery. I mean, the MJOA score of 5 is like extremely bad, but we do know that even with patients with severe myelopathy with an MJOA less than 7 or 8, they do get a little better after surgery. But then he has to be pretty realistic that the amount of functional gain that he's going to get after surgery will be limited, just looking at the chronicity of his neural compression. But yes, I would offer him surgery if he understands that his neurological status is very poor.
So let me pin you down on a number. So if we go back to the neuric scale, obviously I'm biased here. We did the AO North America study. But what grade improvement using the neuric kind of a category scale can a patient expect who has an advanced 5 grade 5 disability?
Yeah, I mean, that's a great question. So MGOS score has been looked at a lot of studies. We do know that anything less than 8 is severe myelopathy, but even these patients do pretty well after surgery. Even when they have severe myelopathy, they do get better. Any patient who has like 10, 12, 11, 13 score, they do fairly well, and they can actually, gain at least 2 or 3 points, maybe after 6 or 7 months. Any patient who is below 8, say 5 in this case, he can probably gain like 2 or 3 scores, which is going to, better than what he is. But from a functionality point of view, is something that has to be, discussed with the patient, that he may not perceive these benefits that much as compared to a person with a higher MGOS score to begin with.
And now I'll pin you down, if you don't mind going back to the MRI survey, Jared. Pretty substantial disease. Again, the MRIs are very hard to interpret, but assume that 4, 5, and 5, 6 has really prohibitive circumferential disease. There's a substantial 2-level cord signal change with a high-grade cord edema around the 5, 6 area. So anterior, posterior only, what is your thought?
So my first inclination would be to do posterior in this case.
And why do you
posterior decompression? Yeah, the main indication is that this is like exaggerated lumbar lordosis. So I think with so much of lordosis, there's a good chance that there's going to be a spinal cord shift or a drift posteriorly. And looking at the MRI scan, there looks to be quite a lot of arthritis in the lower cervical spine. It could be like an end-stage arthritis, as you had very aptly described. My sort of first inclination would be to do a posterior surgery in this case, and that may be the only surgery that I would consider. Long segment like a C.
Sorry, Tarush, you go ahead.
I think it would be something like C3 to 4, 5, 6, 7, C3 to C7 with a long segment decompression. That would be something that will be first in my mind.
And you'd use a fusion, or would you give him a laminoplasty because it's a little bit less invasive? And a recent North American myelopathy study did show that myelopathy treated with laminoplasties had less complications and equivalent neurologic recoveries.
I would be a little skeptical doing a laminoplasty in this patient. Just looking at the amount of lordosis and the C7 or T1 slope is so high. I mean, I would be a little scared about things falling forward in case of a laminoplasty. So I would consider fusion over laminoplasty here.
Now, let me pin you down on C3 as a rostral fixation point. So C3 is a pretty small little lateral mass, and we propose to do a relatively long fixation. Why stop at C3? Why not go to C2? You just told me that you like pedicle screws. You're an exceptionally well-trained surgeon. Yeah. I know that firsthand. So why not stop at C2 and have a much better mechanical fixation?
I agree with you in a sense. I mean, C2 is reasonable, and there's hardly any difference stopping at C3 versus C2. So if the points of fixations are really limited, I would be least hesitant to go to C2. Absolutely no problem.
All right. So Jared, what do we do?
So we went anteriorly. I went for a ACDF C4, 5, and 5, 6. So here's what we see there. So there's the potential for going posteriorly if necessary.
Why was that done? Why was anterior done first? I didn't do this case, so I'm not biased. But why was anterior done first?
The thought was that restoring disc space height would allow for stretch and kind of taking out the buckling in the ligament and flavum posteriorly. So going anteriorly could be all the patient needs, back them up if necessary later. I think that was the idea behind it. Disclaimer: I also was not involved in the end of this case. I just saw him in the ED. But for as far as his follow-up goes, pretty short term follow-up so far, but he's already standing with an assistive device, able to sit up at bedside unsupported, moving all the extremities. Functionally speaking, is the same so far. I think really what we were hoping for, in preoperative discussions with him, at least when I saw him, was we want him to keep being able to feed himself, maybe even make that easier. But we'll just kind of see what happens from here.
And this is a severe myelopathy. Is that postoperative neuroimaging? Is there a new MRI scan or a CT scan done?
Not as of now.
So I want to recognize Dr. Ken Yanamura. He's a longtime colleague of mine here in Seattle, and he's now in, I believe, and correct me if I'm wrong, Ken, in Salt Lake. And he said laminoplasty. And again, I love laminoplasties. This is obviously a severe cord injury, a myelopathy turned cord injury. And I agree with you, and I'm not sure I would have done a laminoplasty as much as I like those surgeries a lot. And Zohar Gogawala, in his myelopathy study here in North America, the most recent one, did point out that laminoplasties had the same neurologic recoveries as anterior and posterior surgeries, fusion surgeries. And interestingly, anterior fusion surgeries had the highest degree of complications, mainly in terms of swallowing difficulty. So there was a so-called equipoise trial where patients were deemed to have the same ability for recovery, but remarkably, neck pain and complications were much lower in the laminoplasty group. Tarush, tell us about the standard of laminoplasty, or the state, I should say, of laminoplasty in India. Is that a commonly done surgery? Is that not so well regarded? What are your thoughts and your perspective on laminoplasty here?
Yeah, laminoplasty is not a very commonly performed surgery in India, at least. I mean, if fixation is to be done, it's usually lateral mass or some posterior fixation, but laminoplasty is not a very commonly done surgery. I think the main reason is the training. Laminoplasty is not something that surgeons are typically trained into. And also the laminoplasty plates are something that are a little cost prohibitive, at least in India.
Yeah, this is an interesting thing because in our country, it's not become super popular either. And there are just a couple of people who have been trained in the technique who really like it. And I love it. I mean, in the US, I hate to say it, one angle is that we as surgeons get paid far less. The implant costs are pretty high, conversely. So this is something that's just never became the mainstay. I think most surgeons would opt for fusion surgery. Jared, what are your thoughts now? You're going to be an attending surgeon a month from now in Virginia Beach. Are you going to offer this patient an anterior or posterior fusion surgery?
I would have gone posterior. So the way that I'm seeing this is he has a pincer lesion that about 2/3 of it is coming from posterior. And so my concern is that going anteriorly wouldn't adequately decompress him. So I think going for, especially with his his functional limitations and everything like that, going C2 to T2 actually might be the best option for him. I would be concerned that a shorter one, with his posture, his functional limitations, his the degree of kyphosis transitioning into his cervical lordosis, that he would end up kyphosing if you went shorter to just try to save spinal segments. So
yeah, I mean, without a doubt, this patient will need a follow-up MRI scan and CT scan in the not too distant future to see how things are going. Dr. Bazem Ishak, the chief of neurosurgery in Heidelberg, Germany, also said laminoplasty is not commonly done there, and neither is laminoplasty much done in Iran, with Dr. Farabash's commentary, much appreciated. Again, this is a phenomenon for me because it's, if well performed, a very satisfying surgery. But again, here I would have probably, given the severity of cord injury, chosen a fusion also. I personally would have gone posterior also with a multi-level C2 to T2 fusion, probably just give him a fait accompli and immobilize his cord as good as possible, given how severe that is. But I would really love to see a post-op MRI and CT scan soon. So
I would like to as well.
All right. Thank you. And let's go for our next fellow. Thank you very much, Dr. Cook. Appreciate your nicely done presentations. Next, we have Dr. James Hicks. He came to us from Alabama, and he's going to go back to Alabama, to Mobile, Alabama. He's going to be a mainstay of spine care there, and he'll also have to do spine trauma. And so he's put two cases together.
All right, so this on down here. So we got Mr. B. So this first case here, 88-year-old, history of esophageal cancer, a seizure disorder, and falls, possibly due to syncope. He does fall off his bicycle, presents to us with this examination with some hand intrinsic and upper extremity weakness, mostly on the left, but also on the right. So he's HAD on presentation. We did start him on steroids. This is his CT scan. So it comes to us as an isolated injury.
All right, this is great. Yeah, sorry, go ahead.
I'm just elaborating. So about 5'6", facet fracture dislocation. Completely jumped on one side and perched on the other. He did have a vert injury on a unilateral side. And I think the biggest thing to note here with his history of esophageal cancer, he did have surgery through the front side of his neck, and he had a gastric advancement or pull through up towards the resected portion of the esophagus.
And how long ago was that roughly?
Actually, I'm not sure, but
14 years ago. So a 14-year
Yeah.
survivor of a pretty nasty disease and a pretty major reconstruction.
Right.
So Tarush, this was just a very recent event. We, due to patient identifiers, don't want to mention the name or the date, but this is a crazy story that only real life can write. This is an 88-year-old cancer survivor of esophageal cancer, lives kind of semi-independently, has a known seizure disorder, has a known syncopal history, likely cardiogenic, and rides his bicycle and then crashes. No bad head injury, unilateral vert injury, mild cord injury, Asia D, pretty gnarly injury. So first thoughts, I mean, it's crazy, right? But you've been to Harborview. This is real life.
Yeah, so that's like a multiple comorbidity with a lot of issues going on. So is that a unilateral facet dislocation, or it's a bilateral? I'm not very sure.
One side is a true fracture dislocation. The other side is perched. So the side, the vertebral artery injury, is the complete fracture dislocation, and he has a V1 injury that I think goes up and down.
You mentioned in V1 to V2. Yeah.
V1, V2. So basically his whole subaxial vertebral artery is gone and not actively bleeding, but he has no intracranial injury. He does not have a bleed. He does not have any ischemia or anything like that. So he has a badly tented cord, most likely, but he has a C4-5-6 posterior lamina fracture, which probably was cord protective for him. Otherwise, he would not be moving. He has mild neurologic deficits, mainly in his hands. He's not hyperreflexic. He has a unilateral, fortunately dominant, I believe, right-sided vertebral artery. You can see a little glimpse of that on the perch side. So how do we approach this? Do we try to do a closed reduction on this guy in the ER? Where do we start with this after we've made sure that there's no intracranial lesion?
Yeah, I think there's definitely a role of reduction by putting Gordon-Bell tongs after he has been imaged completely, including his MRI scans. As you said, he is lucky to have an auto decompression from the backside, so his spinal cord is protected, but this is unstable. So putting him in a Gordon-Bell tongs and doing a reduction maneuver is something that would be the first thing to do, just to get things into alignment. And then take him for the surgery from the back side, not from the front side in this case.
Why not the front side in this case?
Well, it seems that his first side is already completely cooked with so many surgeries and everything going on. So I'm not very sure how easy it would be to do it from the front side.
I concurred with you. I mean, for dislocations, I don't know how it is in your practice. When we have subaxial dislocations, we love to do a closed reduction. We love to do a short segment anti-fixation, even if it's just a damage control surgery, like in an ankylosing spondylitis patient, and then let the dust settle in a day or two, or even a week later, do a posterior fixation as needed after restudying the patient. But I looked at the front of that neck and went like, I'm not going in through that. It was like a bit of a war zone, but it had worked well for 14 years. So how much time and effort would you spend on trying to reduce this mess of a fracture dislocation? And how high would you go? This is an 88-year-old guy. Again, he has this ballooning esophagus pull-through. Was this a gastric pull-through or a colon interposition graft? Do you remember that?
So from my memory, and you all talking about it, that's actually his stomach that you can see pulled up and through and connected.
So he has his stomach and his neck and his throat. So his a true gastric pull-through. So how much time would you spend on reducing them? Do you have a protocol for that in Mumbai? I know in Harborview, we had our traction cart. We had a whole fluoro room set aside for urgent traction reductions, and we spent a lot of time, and we kind of tapped out using the stainless steel tongs, not the titanium ones, at around 80 pounds by memory, roughly. But how much time would you spend in your practice on trying to get him reduced?
Not much, actually. I mean, as soon as we get the OR, we'll take him to the OR, because it's going to reduce eventually. Even when he goes under anesthesia, this is going to reduce. So garden belt tongs is just to make sure that while he goes in the OR, at least his spine is stabilized. And any reduction done before he goes for the surgery is always welcome. But I won't spend much time in reducing him and waiting for the reduction to come.
Yeah. An MRI scan? Did we get an MRI scan, James? And why not?
No, because I don't think that would really affect our management if we're not going to go through the front.
Yeah. Yeah, we did not get an MRI scan. We were not going to go from the front. I like that term. The front was cooked. That didn't come to my mind, but I had to. You brought a smile on my face. I did not want to go from the front. That was clear. So we're going to go from the back side. And a question by Dr. Faiz Al-Shah. He asked for steroids. We gave steroids. James, your thoughts? I mean, you came from Alabama, a major level 1 trauma center. Steroids, yes, no. You follow the debate all year long. Do we give steroids for cord injuries?
Right. It was variable. We mostly did not. That's something I've been thinking about recently, and I don't have a full conclusion on yet what I'm going to do. I think there's a role for steroids, in my view. But I'd have to really see how the patient's doing in the ICU and what their other issues are.
Yeah, so Michael Failings just recently in our master's course gave a wonderful lecture. We've had literally all sides of the equation here. We've had John Hurlburt here, who wrote the famous neurosurgery opinion piece as to no steroids. Michael Failings gave his latest meta-analysis on steroids, and he's actually in favor of steroids. And again, we use the NASCAS-2 protocol here. This patient, again, was hovering around a cord injury. He had a cord injury without a question, but for me, the best time to give it is preemptively. The risk of complications, which are mainly wound infections and pneumonia, aside from obviously diabetogenic side effects, are all manageable. And in our practices, were never a major problem. So I still stick with the NASCAS-2 protocol, 30 milligrams per kilogram bolus if we can get to the patient within 8 hours, and 5.4 milligrams per kilogram drip for 23 hours afterwards. Are there significant scientific drawbacks to the studies of the NASCAS series? Absolutely. And there's absolutely no suggestion that 48 hours works, but within 24 hours, there is a subset of patients in the cervical spine group that had benefits. And again, look at Dr. Failing's excellent recent summary lecture. But we know that it's controversial and it's not incontrovertible. And there are many things around the Michael Bracken study that were problematic in retrospect, and the study results were clearly overemphasized by a number of parties, but on a basic science perspective, steroids help the cord. Any thoughts on steroids? Sorry for the long diatribe here. Tarush, steroids in acute cord injuries in India?
Yeah, so most of the patients with acute cord injuries actually do not come in the interval when the steroids are to be given, but if they do, yes, we also follow the Axis 2 protocol. In this particular case, though, I may not have given steroids just because it looks like more of a root injury than a cord injury. So dexamethasone maybe yes, but solimedrol or methylprednisolone perhaps no in this particular case. But in general, yes, cord injuries do get steroids.
So, and then surgery, you said posterior, so we have agreement. Give me levels. Would you give them just a limited fixation, or would you go multi-level, like coast to coast, like C2 to T1 or T2?
I mean, preferably as short as possible, maybe 2 levels above or below. And I'm going to elaborate a little bit on in my talk as well. Not perhaps a C2 to T2, maybe 2 levels up and below, something like that. But again, it has to be carefully assessed on a pre-op CAT scan if there is a pedicle fracture or lateral mass fracture. That everything has to be taken into account.
So Dr. Ishak from Heidelberg, who's a neurosurgeon by training, told us that in Heidelberg, they have a large trauma center there. They routinely give steroids with appropriate preemptive measures for acute cord injuries, and the complications that were stated in the literature, like infection, pneumonia, are not really a clinical factor if appropriately prevented. And again, for the very old, actually Baz published a paper on the octogenarians with bad C-spine injuries, and he would basically go C2 to T2. So what do we do, Jim?
All right, so applying a good amount of traction. We've all put on 40, 45 pounds or so with Gardner-Wells, obtaining preliminary about half reduced there, and then with fascicectomy, foraminotomy, and C2 down to T1, I believe, with C7 pedicle screws, able to obtain just about a full reduction here, and I'll show the CT scan post-operatively.
So this is not an easy reduction, as Jim said. We didn't spend much time with our traction setup. We tried, we stopped, I think, 45 pounds, and we only got a 50% reduction with that. And the final reduction was done surgically after we did a limited laminotomy to keep bony references there, just remove the loose pieces, then did a screw placement, then did a rod-based reduction. We used a small lamina spreader in the healthy C4 and the healthy C6 lamina and got a cantilever reduction, then did the bilateral rod fixation from caudal up rostral, and took the weights off and locked the rods down, and then did a completion of our laminectomy, I think C4 through C6, so basically leaving C3 and C7 lamina intact. And how did and we did C7 T1 pedicle screws. We stopped at T1. We didn't see a need to go to T2, but that's arguable. How did he do, Jim?
He's done well. Just staying with therapy now, and this is a fairly recent case, so we'll continue to follow and see how he's doing.
So Tarush, 2 questions. So this man has a complete and bad left-sided vertebral artery injury. Was I crazy to put any hardware in on his right side? Should I have gone for really minimal screws? What are your thoughts in terms of a patient who has a unilateral vertebral artery injury? Do we modify our technique on the right intact side in this case?
Not really. I think the incidence of vertebral artery injury, even in putting pedicle screws at C2, isn't very high as long as it is meticulously done. I mean, following the technique that you do, like 2 millimeters of advancement every time, that's what I follow as well. So I don't think the technique needs to be modified as long as one is really careful how to do it.
There's a recent trend in the US pushed by some colleagues with navigation and robots to revisit subaxial pedicle screws, C3, 4, 5, 6 pedicle screws. What are your thoughts on that? Is that just crazy? Is that technology over anything else? The biomechanical advantage is clear, but to me, looking at some of those pedicles, it's just crazy to do that. What are your thoughts?
So to be honest, I mean, aren't trained in putting pedicle screws, and relying totally on technology is not the best thing to do, according to me, unless one has enough, experience in putting pedicle screws without using a lot of navigation. Some of the Japanese colleagues are just brilliant in putting pedicle screws. They can put pedicle screws even in the middle of the night. So totally relying on, navigation, robotic to put pedicle screws at all levels, needs to be carefully, managed and planned. And I'm not very sure if, at least the robots that we have in India, they aren't programmed at least to put cervical pedicle screws. I'm not very sure what's over there.
Now I have this gap in the front now at C5-6. That's not a surprise. The posterior vertebral body fragment, that teardrop fracture in the posterior C5, by the way, reduced nicely. But now we have this big old gap. Do you want me to, or would you advise me to get my ENT colleagues, my oncologic ENT colleagues, to come over here and do an ACDF, or can we rely on the C2 to T1 fixation with reasonably good bone strength there to hold this in place?
Oh, absolutely. I don't think there's any need to do anterior surgery. It looks like a solid fixation.
Yeah. Right. In terms of levels, again, Dr. Ishak and I agree with that. In a very elderly patient, I don't see any reason for motion preservation. And honestly, I don't know how I could have done an instrument-based reduction on this patient without going from stable fixation from the bottom with 2 levels of pedicle screws, one C7, one T1, up to C2. I just going less levels, like C7 lateral mass screws are notoriously bad, but C7, C6 lateral mass screws to C4, I don't think we would have had enough purchase.
Mm-hmm. Yeah, I mean, looking at the post-op, it looks great.
James, any learning points for yourself for Alabama coming August?
No, I think this is great. I think it's, I think I would have done the same thing, actually.
Yeah, one key point was we always at Harvard, we were so fixated on have a complete reduction. This obviously makes us feel better, but even a partial reduction protects the cord usually quite well, but then getting the patient to the OR, I think that's the single biggest thing. We don't leave patients laying around in traction anymore. We try to get them into the OR ASAP and do a surgical fixation. And again, we have done a better job, I think, getting prioritization in the ORs, advocating for our patients more. How is your OR access for an urgent surgical reduction need in a spine? Do you get heard in your ORs? Can you get in there rapidly?
Yeah, I mean, getting access to any urgent surgery is not a problem.
Oh, that's nice. we still fight about it frequently.
Yeah, it's not a problem.
All right, and one more case, I think, if you we can indulge you. Okay.
Indeed. It's a bit of a different story here. So 66-year-old male, previous surgery done years prior, and then underwent a revision outside of here within the past few years. And then we planned for his reoperation in 2021. So that's how he presented to us. Obviously, grossly, there's an issue with his neck, presenting with neck pain, radiculopathy. Before we move on, I was going to show the first post-ops.
So this is something that just drives me nuts, Tarush. Just in the interest of doing anterior surgery, we see with some regularity this bizarre stacked on constructs when there's a global subaxial disease present. And is this something that's, you have a perspective from 2 continents, you're in North America for 3 years and you're back in South Asia. Is this something that's just US where there's just a lot of people who kind of don't follow principles, or is this a reflection of desperation? What's going on here? So here we have a non-union, we have stacked plates, we have a significant ossification of the anterior longitudinal ligament, plus minus swallowing difficulties. What's going on here, and why do we see these kind of weird things?
I think it can be seen everywhere, even in South Asia, I'm sure. There are certain proponents who just like to do anterior surgery, and there are certain proponents who just like to do posterior surgery. So I think that's the key issue. This is a really tricky situation. We have a plate-on-plate situation now, and it's they're like a big ossified at the suprajacent level, that is, I think, kinking onto the esophagus, causing all sorts of swallowing issues. So, I mean, yeah, it can be seen everywhere, but I think there is, to be honest, I mean, there is a little more propensity of anterior surgeries in North America as compared to India, at least.
All right.
Great. Okay, James, we have just a couple of minutes.
So this is the first post-op on the right. And as you can see, that 7-1 non-union is still present there, but we have addressed the other severe anterior disease. And the reason it hasn't been backed up yet, there was a vertebral artery injury during release of the 4-5 foramen to get correction. Moving onward, this was his follow-up months later, still again with the non-union, and again planning for the posterior portion. And then we went ahead and addressed all of this posteriorly, including that non-union.
So the patient had an intraoperative vertebral artery injury during the anterior cervical surgery.
Correct. And so we delayed his second stage for months later. I think it was close to 6 or 7 months later.
Yeah.
So, yep.
And so so non-unions of ACDFs with deformities, what are your thoughts on doing these posteriorly only? So there's a peak cage that obviously had not healed. In retrospect, it would have been nice to probably fix that also. What are your thoughts on kind of doing a posterior fusion deformity correction to treat an anterior non-union?
Yeah, I think it's the way to do. I mean, posterior fixation gives you multiple fixation points. It allows you to gradually correct the deformity, securely, and it allows you to, have like a robust fixation for the backside. So going posteriorly, I think it's the way to do. Absolutely.
Any thoughts on the vertebral artery injury? What do you do when you have one? You said they're very rare. This was a case where we did have one. What do you do in surgery?
That's a tricky. Well, I mean, yeah. First of all, you pack it, and then you ask our vascular guys to come in, and so that's why it's very important whenever we drape the a patient for an ACDF, we always drape it for a worst case scenario. So wide draping is very important in case they have to clamp it or redirect the flow. It's always important. We always drape extremely wide, irrespective, even if we are doing a single level ACDF. We have a vascular team come in, and then they assess what's going on, and if they feel that the flow is there, sometimes they coil it, or sometimes they do a post-op angio and see how's the flow. Sometimes they also extubate the patient, or at least kind of do a wake-up test and see how the patient is doing and take it from there. So sometimes these vertebral arteries can heal themselves also. It's not that always they need a coiling or a repair. So a lot of permutation and combinations can be there. There's, at least in my eyes, there's no fixed algorithm or flowchart that can be followed.
Dr. Hicks, how'd the patient do?
It's done well. So I think last follow-up was back in 2022. And these were the, these were the latest films that we had, and he was moving on to union. So doing well.
So great questions, great cases. Thank you. Couple of follow-up questions to the chat room. Dr. Marcel Sinkari, sagittal balance films. No, I mean, that's a great question that I'll ask Dr. Rustagi next. That subaxial parameters versus T1 slope. How do we assess the global balance of the cervical spine, the big picture? The other question was by Dr. Amin Hanin, who we always love having participate here. Anti-inflammatories and neural compression, mechanical neural compression. Great question again. I'm in favor of steroids and usually use the NASCAS-2 protocol, and Dr. Rustagi, I think, is a similar mindset. Correct, Tarush?
Yes, that's right. This patient needs, I would have been steroids as well.
Yeah. So it's a great honor and personally extremely meaningful for me to introduce Dr. Tarush Rustagi. from Delhi. He is a very highly regarded spine surgeon. He did his training in India. He did his fellowship in Mumbai, and then he did 3 years of fellowships in the U.S., in upstate New York and Syracuse, then at UW, and finally then in Ohio State with our good colleague and friend Hudi Mandel, who, as you know, chairs the annual spine tumor course here. And Dr. Rustagi has continued to publish extensively. He's a wonderful surgeon, as I can personally attest to, but he's also a great father and a friend, and a very thoughtful surgeon. His publication history is extensive and can be followed easily on PubMed. And he suggested that we talk about complex posterior C-spine fixation. So we thought we'd show you some recent cases just to show you that the discussions and the discovery and the variables of humankind never cease to amaze us, and the challenges are certainly out there. So very curious to hear your thoughts.
So thank you very much. I just want to make sure, is my screen visible?
Yes, you have nothing to disclose.
Okay. Yeah, so I have nothing to disclose, and thank you for having me here, and an absolute pleasure and an honor back to my alma mater, though virtually. So the topic that I chose for this presentation was something very simple. It's something that you may all find it a little relevant in day-to-day practice. And at this stage, I want to acknowledge my colleagues and my partners in crime. And so this is not going to be a big academic talk. This is not going to be a big data or a great invention. It's just a food for thought and sharing some experience and keeping things really simple and practical. So let me start with the case of a 57-year-old male with a typical cervical spondylotic compressive myelopathy with segmental low PLL with a poor MGOS score. And he undergoes posterior C3 to C6 laminectomy with a C2 to C7 lateral mass fixation and rods. He has a good clinical outcome, good MRI scan showing good canal decompression. 6 months down the line, he has a symptomatic kind of rod fracture on one side and a screw fracture that had to be revised. Or another case of a 56-year-old male patient who had endemic sclerosis with flowing osteophytes encroaching onto the spinal canal with severe myelopathy. And he undergoes a posterior C2 to T2 fixation with lateral mass screws and C2 and pedicle screws in C2 and thoracic spine with kind of an oblong section of his lamina. It was all one piece. So again, he did well clinically, but 8 months down the line, this patient had an asymptomatic right side rod fracture. And I'm not very sure if it's visible in this picture. But we can appreciate here that the rod on the right side had fracture right at the cervicothoracic junction, where there seems to be a lot of bending and contouring, and a lot of notching must have happened to the rod just to put it onto the pedicle, onto the screw head. So we know that these rods are flimsy and they can break. Even if you ask these patients to use a pillow under their head after surgery, these rods can bend. And one can imagine what's going to happen by using 2 rods in cases like these, fracture dislocations, or notoriously unstable ankylosing spondylitis fractures, or deformity correction done only from the backside, certain tumors of the occipital cervical region, or in cervical tumors. And that kind of forms the background of the study. So posterior cervical surgery is very common, and still there are issues with rod fracture and rod failure up to, I'm sorry, it's not 40, it's 4 to 10%. And the key issue is the limited points of fixation. And it especially gets challenging in revision surgeries and once you do laminectomies, and in geriatric population, of course, poor bone quality adds to the problem. So we know if we want to bend these rods, notching is a real and really an under-recognized problem. And we know that these rods can easily break and fracture, especially if we are using cross connectors and removing the cross connectors. So these rods can fracture. So what are the options there, to augment them? Anterior augmentation, of course, it's a beautiful option, but it is not always feasible and doable, and we'll see in certain examples. Hooks, of course, is not an option in cervical spine. Use of wires or cables as we use in the thoracic and lumbar spine. If used in cervical spine is really limited because neural decompression is an essential part of cervical spine surgery. use of materials such as cobalt chrome or larger diameter rods is something that has been explored, but they aren't easily available and there aren't much clinical experience into using these. In all pedicle screws, of course, as we discussed in the case presentation also, it's not that comes naturally or it's not a part of our routine training. So this study, cadaveric study by Chris Hammers, did show that cobalt chrome rods are, much better over titanium rods. In this study by Professor Vijay Goel from Toledo University did show that increasing the rod diameter from 3.5 to 4 to 4.5 significantly improves the overall rigid construct. So this is where we were, looking for something strong posteriorly to hold things together, especially in situation of gross cervical instability, not in typical degenerative spine problems, especially when we are not thinking of doing anterior surgery or anterior surgery is not possible. And that's the topic of this presentation, a 2+ or using more than 2 rods in the posterior cervical spine. And this is not something new. We have been using these in cases like these, a Charcot spine with gross, like complete dissociation of the spine, which are fixed anteriorly and using posterior rods on the backside. Or cases like these of lumbopelvic dissociation or posterior ring injuries that have to be meticulously planned and using multiple rods and screws, they have to be, fixed pretty robustly. Or a typical case of adult deformities where the use of third rod or the fourth rod is kind of norm now, especially used like a kickstand rod where the spine, the collapsing side of the spine is fixed onto the pelvis to support it. Or in cases of tumors like these L5 plasmacytoma, where the traditional teaching was actually doing much complex anterior corpectomies and reconstructions. And with the advent of neoadjuvant therapies, they can just be fixed securely from the backside and let the medicines do their job. And this has been validated, pretty effectively in clinical studies and biomechanical studies as well. So either we can do the surgery from the front side and have the team doing the, anterior reconstruction, and we can have 2 rods on the back side, or we can just have, multiple rods doing the Superman work while the remaining team is out. And that's the concept of placing a combination of pedicle screws, lateral mass screws, and then using 3 to 4 rods on the backside. So obviously this needs a careful planning because we're using a combination of lateral mass and pedicle screws. It needs to be planned beforehand, but what it allows essentially is that you can choose the pedicle screw that is easiest to put, that has the least trajectory to put, and that is safest to put, mainly on the right side. So I'm going to exemplify with a few cases. This is one of the earliest cases we did around 7 years back. 70-year-old male with severe mechanical neck pain radiating to his left upper limb, chronic smoker, had a swelling on the right side of his neck. And he had a right side C6 deficit, but in severe pain. I mean, he literally was holding his head when he came to the clinic. And that's how his imaging looked, like a C6 destructive lytic lesion with a kyphotic collapse. It looks like a very juicy case to do an anterior reconstruction and fusion. When you look at the soft tissue shadows, I mean, something is going on. Something is pushing the visceral structures, not only ventrally, but also on one side. And that's his MRI showing some, infiltrative mass, which is pushing the trachea and the esophagus on the other side, and, a massive lesion on the front side, making anterior surgery really tricky. And that's his CAT scan, again, showing the same things. So since anterior surgery was not possible in this case, so we did a biopsy from the front side, from the anterior side, and then we fixed the spine, a relatively short segment fusion using a combination of pedicle screws and lateral mass screws. And we were really hoping that it stays, and we didn't have much salvage options if this would have failed, because you would have eventually needed some radiation. And we know that doing surgery after radiation is a mess. So that's his 15 months. It came out to be lung mets, adenocarcinoma. He had chemo and radiotherapy, had a great oncological outcome, good survival. And that's how we were kind of relieved when we saw this recalcification on the C6 vertebral body. And that's his 7 years follow-up. Absolutely okay. His anterior skin had completely scarred down. So doing an anterior surgery was kind of impossible. but he did pretty well. Or another typical case of a 32-year-old. This is a young guy with a road traffic accident with a C5-6 fracture dislocation. And he also had extensive anterior soft tissue injuries from shrapnel, glass and metal. And that's how it looked like. So this image is not his because I didn't have a clinical image, but that's what it looked like. So anterior extensive soft tissue injuries, as was presented in one of the cases. Doing these surgeries from the front side is difficult. So we reduced him with the help of tongs with a 10 kg weight. It's reduced pretty effectively. And that's what we did. We did a relatively short segment fixation here. And we use a combination of multiple rods. We can see, especially on the right side, on the non-dominant side, that we were able to place lateral mass screws and pedicle screws in the same vertebra. But obviously, this needs a little careful planning beforehand. This patient had a really good outcome. He remained ACI, of course, but he is doing pretty well. Or another case of a 78-year-old male with a Parkinson's and Alzheimer's, and a typical fracture that looks pretty benign to begin with, but they are extremely unstable. They have extremely high propensity to collapse and cause neurological deficit. So we have been treating these fractures only posteriorly. There have been some advocates of doing an anterior sort of support, putting a buttress plate, putting bone grafting from the front side. But we have not many, but around 2 or 3 cases, we just place multiple rods there with a combination of pedicle and lateral mass screws. What it also allows is that we don't have to bend these rods much. Just imagine connecting this single rod, connecting the C2 pedicle screw to the lateral mass screw, the pedicle screws. Sometimes they have to be, bent so much that they are literally on the verge of, breaking. Or this case of cervical kyphosis with OPLL, with again significant myelopathy. So we decided to do the surgery from the back side, and we placed hardware, robust hardware from the back side. We did far facet releases. And then we tried to lift his Mayfield up just to give it a good correction, a little correction. And we heard a loud pop. We were all really scared, but the patient was doing okay. His neuromonitoring signals were okay. So we just locked him into place, and we thought that we'll come back again as needed. So this is how it looked like. And we can see here in the red numbers that his deformity had actually corrected from 18 degrees of kyphosis to around 5 degrees of lordosis, which was fairly okay. And that's his 3 months post-op scan. He was clinically doing very well. His spinal cord well decompressed. And the loud pop that we heard came from here. The C5-6 had a kind of an osteoclasis. So we were glad that we had a good fixation, robust fixation from the back side. We didn't have to come back to do an anterior surgery. Or this case, this is my partner's case, but I was a part of it, a case of dystonia with myelopathy. This patient came with this picture. So we can see a kind of a pseudotumor or a pannus formation in the occipitocervical region. And on the back side, we can see kind of a fluid cleft demonstrating some instability happening there. And that's his CAT scan, which is even more, impressive. We saw earlier what's the importance of CAT scan in one of the cases. It really helps to identify what's going on. So this patient had not only a destructive or erosive disease affecting his fibers, his C1 and C2, but also his occipitocervical ligaments were completely gone. So that's how he was reconstructed. So we did an occipitocervical fusion. And here we used the third rod, like a kickstand rod, to support his collapsing side onto the cervical spine. And he had really good outcome. He's doing pretty well. Of course, his range of motion is poor, but he's at least straight. And this one quick class case of a 52-year-old male with bilateral shoulder pain, bilateral upper limb radiculopathy, and a lymph node mass which was biopsied to be a Castleman disease, which is essentially an infiltrative lymphoproliferative disorder. And the main therapy is immunotherapy and chemotherapy with a SIN score of 11. And that's how it looked on a CAT scan, complete erosion of the C3 vertebral body, both on the front side and the back side. And these cases are really difficult to reconstruct from the front side. Not only not only the pathology itself, but also the access in the patient who has very short neck. And what these patients actually needed was a strong fixation on the backside. So we just placed an additional C2 laminar screw here because the disease was C3 and we wanted to limit the proximal fixation point to C2. And then we used a third point. This patient is undergoing chemotherapy. I think he came back at 1.5 years and doing very well. So we don't have a long phase, 16 cases of variable etiology, but we have been able to use these third or fourth rod pretty effectively, especially when anterior surgery is not possible or not doable or we want to avoid it. No real issues in terms of any surgical issues or any major complications. Good clinical outcome with reduction in pain scores, neck disability index, and overall satisfaction. When we started doing these cases, there weren't many cadaveric study looking at third rod, and we didn't have an access to do this cadaveric study or biomechanical study, I should say. But this study back in 2020 in Neurospine did show that use of 3 rods was biomechanically, most stable in all movement planes. They didn't use the pedicle screw and the lateral mass screws, but at least it did show that even an addition of a single rod is very effective. So that's a kind of a flowchart of our indications in cases of cervical deformities where one can avoid doing an anterior release and fusion surgery. Or in case of ankylosing spondylitis, it has come out to be pretty handy where we can definitely try and avoid anterior surgery because these patients don't tolerate anterior surgeries very well. In cervical tumors, where we want to either leave the anterior, cervical area virgin for a possible future surgery. In case of cervicothoracic fixation, it may be used as an alternative to a tapered rod because tapered rod do have a tendency to fracture actually at the site of taper. And in cervical trauma as an alternative to circumferential fusion surgeries in select cases. So yes, there are significant limitations. The biggest one is we haven't compared it to 2 rods. And we haven't compared it to otherwise available, rods such as a 4mm rod and cobalt chrome rod, mainly because these aren't that easily available, or we don't have much clinical experience, as I said. So in conclusion, I think the concept it's just a thought of keeping the option of using multiple rods in cervical spine in certain specific situations where either the anterior surgery is not possible, not doable, patient is not fit enough to do an anterior surgery or a long, a complex surgery. It does allow to have a very robust fixation. And it also allows you to, choose your pedicle screw. That's a big plus because placing all pedicle screws does increase the complications. So you can really choose which pedicle screw you want to put. And that's how we have been doing this in past couple of years. So that's the end. Thanks again. And it was my pleasure. And it does bring back memories of my time at SNI and SSF, spending some great time with, great colleagues and mentors. Thank you very much.
Very nice, Tarush. So can we go back to some of your slides? So I wish my partner, Dr. Bob Hart, would be here, but he is unfortunately out with his wife's illness. And he has kind of been propagating multi-rod constructs as well. So going back to some of your multi-constructs, so he's very much in favor of that also. Go back a little bit more. There was a case that I want to pick on. Yeah, for instance, this one. So a couple of thoughts. So when he does those, he does try to do crosslinks of various rods together to kind of create a true unit rod between the shorter working rods and the spanning rods. Is that necessary? I didn't see any like small side-by-side connectors to create kind of a unified rod. They're kind of independent overlapping rods. What are your thoughts on that?
Yeah, I think it is definitely advisable to connect the short rod with the long rod. We didn't have a small connector in this particular case, but yes, in general, if there's a possibility of connecting the short rod to the long rod, that I think does increase the construct strength, especially learning from the, I mean, from the thoracolumbar and the lumbosacral spine. That's what we typically do. So in principle, yes, but in general, we want to limit the use of cross connectors as much as possible, because cross connectors do act as like, breakage points. If there is excessive stress at the place where you're using a cross connector, then it can actually fracture at the site of cross connector.
So then the next question is, in my practice, for me, one of the biggest breakthroughs for posterior C-spine fixation was the introduction of 4.0 rods. I rarely use 3.5 rods nowadays. I'll use them in very small statured people with some osteoporosis, so I don't have a big deformity correction, but just that 0.5 millimeter caliber jump seemed to make a huge difference. And like in that one case that I showed, that I think Dr. Hicks showed with the vertebral artery injury, where we used a dual core rod. I will use the dual core rods when we bridge the cervical thoracic junction. So what are your thoughts on 4.0 relative to 4 rods using 3.5 rods?
Oh, absolutely. I mean, I personally, we don't have access to a 4.0 rod that frequently, but it has been, at least in a lot of biomechanical studies, the latest one coming from 2022 did show that just increasing a 0.5 millimeter makes a huge difference in terms of the strength of the rod. Absolutely. If somebody has an access to a 4.0 or perhaps a 4.5, I'm not very sure 4.5 rod is available, but if that is available, especially in these situations, that's an absolute yes.
So then Dr. Tasha K. Walker-Palmer, again, wanted you to extrapolate, and maybe you can select one of the other cases for that. Can you explain again how you can use pedicle and lateral mass screw fixation in the same vertebra? So you had a couple of great cases for that earlier.
Yeah, so obviously the patient's anatomy and morphology has to allow placing both the screws in the same vertebra. But typically we place the pedicle screw first from, using Dr. Abumi's method, like a funnel technique, just based on lateral fluoroscopy. And once that screw is actually placed properly, then there's actually enough place to put a lateral mass screw from medial to lateral side. Obviously, the starting point of this lateral mass screw has to be a little more inferior and medial as compared to a regular lateral mass screw.
Yeah, so as I look at this case, yeah, this is very evocative. So the pedicle screw rods run lateral in your construct, and the lateral mass screw rods are put medially. So that's very clever. And yes, there's some vertebra where you have basically quadruple fixation, such as in that C4 vertebra rostrally. So that's very cool. Do you have any mechanical comparisons of basically rod fixation that relies on pedicle screws only, so subaxial pedicle screws only versus lateral masses, or 3-rod fixation? So do we, this is from Dr. Tariq Sohail, where does the biomechanical comparison land us when we compare pure lateral mass screws, pure pedicle screws, and a 3-rod construct?
So pure pedicle screws are definitely one of the strongest constructs. Absolutely no doubt about that. They have a much higher pull-out strength. And if somebody is trained and is very good in putting lateral mass screws, that I think even 2 rods should be enough. Having said that, as I said, our training in putting all pedicle screws is really limited. At least my personal training isn't that great in putting all pedicle screws. I really choose pedicle screws very, very carefully and selectively, which I'm sure I'm going to negotiate. Otherwise, I just skip it. But I think it's a great topic to just observe biomechanically how they would fare, all pedicle versus 3-rod versus all lateral mass. And I'm pretty sure all lateral mass is going to be the weakest. All pedicle screw is going to be the strongest, and 3-rod perhaps it may fare equally as pedicle screws, or maybe a little better as well. I'm not sure, and that's a true answer.
So then a excellent question by Dr. Faiz Ali Shah. He said, posterior fixation, restoring lordosis. So how much can you improve lordosis? I'm paraphrasing his question a little bit here, by having a 4-rod construct. Like maybe, I mean, this is a very nice resolution that you achieved here, but how much do you want to try to optimize? How much can you optimize lordosis if you use a 3 or 4-rod construct relative to a normal 2-rod construct? Does it make it harder to restore lordosis because you're trying to accommodate more hardware?
I think essentially the deformity correction first, whenever we try to achieve, is done over 2 rods, and then the additional thing, 1 or 2 rods are placed at the end of the surgery just to securely fix it. So the principle of deformity correction, whatever it is, remains the same, even if you use 3 rods or 4 rods, because you're going to correct the deformities based on only 2 rods, like we do typically. And then the 3rd rod is just kind of onlaid, put on the screws just to securely lock it into place.
And do you mind going back to that cervical dystonia case? That was a pretty wild case that you showed there. So when you have these kind of lengthy fusions, what kind of graft do you use? Do you use an autologous iliac crest graft? And again, here for me, the weakest spot is actually the craniocervical junction, not so much the subaxial spine, although I see and I appreciate the deformity correction that you did in the subaxial spine there.
Yeah, so we did use autograft in this case because we also did a laminectomy in this patient. So we did use autograft, and we did try to bridge the occiput onto the C2 like an onlay graft. And it's not seen over here. We haven't had a CT scan done on him lately, but we did try to create a notch on the occiput and put it on the C2 lamina like an H-shaped graft, and secured it firmly with the help of vicryl stitches. So that's how we typically do it.
And again, here, the kickstand rod that you very evocatively put, one of the questions came from, I think, who wrote that? Yeah, Dr. Faiz Ali Shah wrote that. You used the kickstand to push this patient's torticollis up more or less. So this is a true kickstand function, correct?
That's right, yeah.
Yeah. So the concavity of the deformity was basically supplemented and reduced. I think your observation about minimizing notching of rods is a really important one, because titanium, when we bend it more than 60 degrees, and depending upon how we bend it, if we create significant notches in it, will clearly have substantial and actually almost shocking fissures in it, but you gotta obviously do what you gotta do. So do you use more, if you have the option of titanium or cobalt chrome in the cervical spine, do you use more cobalt chrome then?
Yeah, if it is available, I think if it is easily available and cost-wise it allows, then in these cases, I would definitely, I think, would personally want to move over to cobalt chrome rods. But availability is a little issue, so it's kind of a a makeshift arrangement. I mean, till we get the COCR rods.
My partner, Dr. Hart, would immediately want to point out that there's a newer metal called rhenium. He has some interest in that. That is apparently super resilient, super stiff, but I have no experience with that. He's put it into a couple of patients, but again, this is just very out there. So as we are right now in the cases, you saw 4 cases, Tarush, and then we'll have to stop. Which one of those 4 cases would you have done a 4 or 3 rod construct on? So we had a couple of challenging cases. We had the patient with the C1 to C3 fusion. We had the patient with the very ugly myelopathy that was missed. We had the patient with the fracture dislocation. And then we had the patient with the staged anterior-posterior reconstruction. Which one of those patients would you have used multi-rods on?
I think typically the patient where the last patient who had like a cooked anterior viscera, that was the case where I would have probably considered placing, which had kind of an anterior opening, a wedge opening in the front. That was a case where we may have considered putting an additional 3rd or 4th rod.
Yeah. So yeah, no, that certainly would have struck me now seeing your talk, and I have to probably revisit that a little bit more, also in my own practice, because I've just not found a great need for it. But my partner, Dr. Hart, has done that a lot, and seeing your very nice talk and nice results, I'll have to probably open my mind a little bit more to it. Tarush, it's so good to see you. You're a wonderful fellow here, and you're an excellent surgeon, and it's so nice to see you at least virtually. I hope you and your family are well and safe, and stay in touch, okay? And thank you to all the members of our international virtual community who communicated with us and participated so actively. Take care and be well.
Absolutely. My pleasure, Dr. Chapman. Good to see you. You're young as always.
Thank you. Bye-bye.
All right. Bye.